The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everyone. Thanks for joining us today. This is Judy Burleson, the ACR Senior Advisor for Quality Metrics. I just wanted to let everyone know that all your lines are on mute. When we get to the Q&A portion of the presentation, if you just raise your hand using the little icon on your screen, or you can always type in your questions in the chat box, and we'll get to those questions as well. I'm going to go ahead and get started because there's a lot of information to go through today. I just want to thank everyone for participating in our discussion about PQRS 2014, talking about the changes that have come about, how the program links to the physician value modifier, and what the value modifier may mean to your practice. Just quickly, the history of PQRS. It was a program that began in 2007, incentive-based voluntary quality reporting program. And just to give you an idea of how the program has grown through the years, in 2008 there were 76 measures. This year there's 284. The high point for the incentive was in 2009 and 2010, when it was 2% of total allowable Medicare charges. And for last year and this year, the incentive is now at 0.5%. This year is the last year for the PQRS incentive, and penalties for not participating began last year with a negative 1.5% of total allowable charges. Looking at an overview of the changes in 2014, and we'll go into more detail on each of these, but there are increased reporting requirements. There's an emphasis on the use of the National Quality Strategy domains, so each measure has an associated domain. There are additions and deletions of quality measures. A new option for participating in PQRS is the Qualified Clinical Data Registry. EHR reporting is now an option for group practice reporting option groups, whereas before they were not eligible to use that. Measures groups are now only reportable through a traditional registry rather than being able to report them through claims as you have in the past. And with the increased reporting requirements, there is now a measure applicability validation process for registry reporting. The administrative claims option, which was an option in 2013 for avoiding penalty, has been eliminated. Just to quickly look at the National Quality Strategy domains, these are based on the Institute of Medicine 6 priorities for healthcare, and have been modified for the PQRS program to be effective clinical care, communication and care coordination, efficiency and cost reduction, person and caregiver-centered experience and outcomes, community and population health, and patient safety. Quickly looking at the incentive penalty amounts for this year and the next few years, as I said, in 2013, the incentive was reduced to 0.5%. If you also participated in the maintenance of certification additional incentive, that's an additional 0.5% for a maximum of 1%. That's the same for 2014. And as I said, this is the last year for a PQRS incentive. However, there's a potential for an upward adjustment through the value modifier program. The penalties did begin in 2013, but they will not be assessed until 2015, so there's a 2-year cycle. The penalty in 2015 based on 2013 reporting is a negative 1.5%, and for 2016 and 17 based on 2014 and 2015 reporting, it is a negative 2%. Eligibility for the program is physicians and other eligible providers who bill under Medicare Part B fee-for-service and who use an individual national provider identifier, or NPI, when billing. So looking more closely at the reporting requirements for 2014 to obtain an incentive, to become incentive eligible, the requirement was increased from 3 measures to 9 across 3 national quality strategy domains. So you must report 9 measures across 3 domains unless only 1 to 8 apply to your services. You must report 50% of the Part B fee-for-service cases per measure. If you report less than required, then if you report less than the number of measures required, then you will undergo validation. Alternatively to reporting 9 measures, you can report a measures group. And we'll talk about that a little bit more in a minute. To avoid the penalty for 2014 participation, if you're incentive eligible, then you'll automatically avoid the penalty. You can report at least 3 measures covering 1 national quality strategy domain. And although you may still be able to obtain an incentive by reporting less than 3, if you do report 3 at the 50% rate, you will avoid the penalty. If you report less than the 3, then again you will go through validation to see if you could have reported more. And looking a little more closely at the requirements, because it is the requirements vary a little bit dependent on the method that you report. I won't go through this in great detail, but basically for claims and a traditional qualified registry, you report the 9 measures across 3 domains, or if you report less, then you'll be subject to the validation process. If you use an EHR, which must be certified technology, either a direct EHR or a data submission vendor, then you report the 9 measures across 3 for the incentive, or report what you can for which there is Medicare patient data. You can't, whereas in the EHR incentive program, you can attest to meeting certain measures without patient data. For those measures to qualify for PQRS, you have to have some patient data. You can't have a 0% performance rate. For measures group reporting, which is through registry only, you report 1 measures group for at least 20 patients, 11 of whom must be Part B fee-for-service patients. You can report either for the full year, January through December, or July to December. The requirements for avoiding the payment adjustment using a measures group are the same as for meeting the incentive. The new option in 2014, the Qualified Clinical Data Registry, and we'll discuss this more in a few minutes, but you must for the incentive, you must report 9 measures across 3 domains for 50% of applicable cases. At least one of the measures must be an outcome measure. And for the Clinical Data Registry, the patients do not need, the only requirement for Medicare versus other payer is that there must be at least 1 Medicare patient on the cases that you report. To avoid the penalty using the Qualified Clinical Data Registry, you report 3 measures across 1 domain. 1 must be an outcome measure. And looking at the requirements for groups that have self-nominated to be a GPRO in the group practice reporting option, the requirements are basically the same as for individual eligible professionals. However, there's only 3 methods through which a GPRO can report, one being the qualified registry, the traditional registry, an EHR, or using a survey vendor to report CG CAPS measures. The CG CAPS measures are basically the patient experience of care survey measures. You can report all those measures and then report 6 other measures across 2 national quality strategy domains. And that is only an option for GPROs with 25 or more EPs in the group. So those are basically the rules. Now how do you play? Well, claims-based reporting is still an option. That is the simple, easiest method to implement. You basically add CPT2 codes to your claims when you submit them for reimbursement. You choose at least 9 measures across 3 domains, or if less than that apply, report 1 to 8, and then that's subject to validation. You can use the PQRS traditional registry, and trying to distinguish this registry between the qualified clinical data registry by using the term traditional. So that is the type of registry that's been that has been an option for a number of years, such as the PQRS Wizard registry. Those registries are basically collecting the data on the measures for eligible providers and then submitting the data to CMS. The requirements for using a registry are the same as for claims. That is, report 9 measures across 3, subject to validation if you report less. You can also report the measures group through the registry. A measures group is a set of 4 to 6 measures that are clinically related. And as I said, you report all the measures for 20 patients, 11 of whom are Medicare. And to point out, there is a new measure group in 2014, optimizing patient exposure to ionizing radiation, that is applicable to many radiology groups or radiologists. Actually, I'll just say radiologists because groups can't report measures groups this year. And we'll talk a little bit more about that measures group in a minute. So the new option, the PQRS Qualified Clinical Data Registry, or the QCDR, is different from a traditional registry in that it may include both PQRS and non-PQRS measures. The Qualified Clinical Data Registry is looked at as a quality improvement registry where comparative benchmark information is provided to the participants in the registry. And they're typically specialty society registries such as the ACR National Radiology Data Registry or NEAR-DEAR. As I said, you're allowed to report on non-PQRS or PQRS measures, and you can combine non- and PQRS measures to successfully participate in PQRS. And just to let you know, the ACR did self-nominate to be a QCDR in 2014, and we will learn by the end of May whether or not we have been approved for that purpose. And the QCDR is an option that you might want to consider because potentially it can meet both PQRS requirements and maintenance of certification Part 4 requirements by using the registries. The group practice reporting option, or GPRO, is open to groups of 2 or more eligible providers who self-nominate to CMS to become a GPRO. If you are a GPRO, then everyone in the group will obtain an incentive or penalty based on how you report, even if not everyone in the group has measures to report. So you select measures as a whole, the group selects as a whole which measures they intend to report, and report on at least 50% of the cases across the group. You must report using a traditional registry. You can't use the Qualified Clinical Data Registry option this year, although I know that has been of concern to practices and to CMS as well, so that may be an option for GPROs in 2015 to use the Qualified Clinical Data Registry option, but it's not this year, so it's the traditional registry, the survey vendor, or an EHR. So those are the methods to participate, and then you need to think about selecting measures. you first review the measures relevant to radiology. You can look at the ACR web pages on PQRS, and there are lists of, which we'll look at in a minute, but there are lists of measures that are mostly relevant to radiology groups and radiologists. You want to consider whether you could report the individual measures or look at measures groups, such as the Optimizing Patient Exposure to Ionizing Radiation or OPEIR measure group. Look at, through your practice, could you report diagnostic radiology and nuclear medicine measures? Are the interventional radiology measures applicable to some in your practice? Or if you're a radiation oncology group, there are distinct measures that you could report as a RO group. And we'll talk again we'll talk about the OPEIR measures group. So this is a listing of the measures most relevant to diagnostic and nuclear medicine practices or radiologists. I've added the second column is the National Quality Strategy domain that's been assigned to each of those measures. So the shorthand for that, PS, is patient safety, E/C is efficiency and cost reduction, CCC is communication and care coordination. So the first 1, 2, 3, 4, 5 measures are most applicable to many radiology practices. The biopsy follow-up measure number 265, I probably should have included that in the interventional radiology list of measures because it does include evaluation and management CPT code in the denominator, so it's probably more applicable to some interventional practices. The last 3, cardiac stress imaging, may be applicable to some radiology practices, but those are highly specialized. Looking at the interventional radiology measures, these are, many of these measures do include evaluation and management codes and some interventional procedure codes, so that is why they may be applicable to interventionalists. The first 4, 5, well, the first 4, 20 through 23, are also contained in the perioperative measures group. So you could either report them individually if not all of them apply to your practice, or you could report them as a measures group if they all apply to your services. So let's take a little closer look at the OPEIR measures group. So if you're reporting a measures group, you would need to report all 6 of these measures. And the idea behind the measure set is to look at different ways to optimizing patients' exposure to ionizing radiation. The first one, 359, utilization of standardized nomenclature for CT imaging description. That is kind of it's not very descriptive what that actually means. But the point of that is actually to pair it with the radiation dose index registry participation measure. And the idea is that you're standardizing the exam names for CT exams across scanners, across your institution, across your system, so that when you report those imaging exams to a registry that you're comparing likes, so that they're not a CT head is different than a CT brain, so you know which exams mean what. The second measure, 360, count of potential high-dose radiation imaging studies, is basically tracking in the radiology report exams, known exams that a patient may have had, so that it brings awareness to both the radiologist and the treating physician of the number of exams that a patient has had. The radiation dose index registry participation measure is that you're participating in a quality improvement tool. This does not specifically point to the use of the ACR dose index registry, although that is an option for the measure, but it allows for institutional-based, local-based registry where you submit exams with specific data elements included in submission to a registry in order to look at your overall CT dose exposure from the exams. Number 362 and 363 we call imaging sharing measures, and it's basically the two of those are making your CT images available across systems, across entities, not just within your hospital or your hospital system, but making images available and searching for images in basically a health network where you can see images from another facility outside of your system. So if a patient comes to your site and has had exams at another location outside of your system, potentially you could reduce duplicative studies. The last one, 364, looks at appropriate follow-up imaging of incidentally found pulmonary nodules. And that's basically using the Fleshner Society guidelines. Let's take a look at the measures that the ACR has proposed for inclusion in the QCDR. This is a list of the PQRS measures that we intend to support in 2014 if we are qualified. So it's the basic diagnostic radiology, nuclear medicine, and a few of the measures that interventional radiologists could report. We've also included 5 of the measures from the OPEIR measure set. And the really exciting thing here is that whereas if you report using a traditional registry, if you report the measures group, you have to report all 6. If you are using a qualified clinical data registry, such as the ACR's, hopefully approved, you can select these measures. You don't have to report all 5 of them. We've only included 5 because we have our own participation in dose index registry measure. But you can pick and choose amongst the measures in the OPEIR set if you're using the ACR qualified registry if we're approved. Taking a look at the non-PQRS measures that we have proposed as part of the qualified clinical data registry, we were limited, as all QCDRs were limited in 2014, to 20 measures, 20 non-PQRS measures, as CMS gets a handle on what these QCDRs will be. We were limited to 20, so we selected measures across each of our registries, trying to take into consideration the need to report 9 measures across 3 national quality strategy domains. So, for example, we have 6 from the National Mammography Database, 5 from the Dose Index Registry, and 6 from the General Radiology Improvement Database. So what if you can't find 9 measures across 3 domains? First, there is a tool that CMS has provided called the Single Source Codemaster. It's an Excel file where you can, someone in your practice management, your coding staff may be able to use this file to go through and, based on CPT codes that you bill, look for measures that are associated with those codes. So you may find some measures that you didn't know that you might be able to report. Once again, you might want to consider the OPEIR measures group. If you can do all 6 of those using a traditional registry, you can do that and be done. Consider the QCDR option if the ACR registries are approved for that. And if all else fails, review the measure applicability validation process, which will be applied to your participation if you have reported less than 9 measures or less than 3 domains, but you have done that successfully. That is, that you've reported 50% of your cases for the measures that you have reported. So the measure applicability validation process, better known as MAV, is really key this year with the increased requirement of 9 measures across 3 domains, because it is difficult for many individuals or many groups to find that many measures. The MAV really comes into play. And so it's the process to determine if additional measures could be reported. There's a separate process this year for claims and registry, so there's a MAV for each of those types of reporting. And just to let you know, this is important, that measures groups are not considered as part of the MAV process. So if you reported 3 measures and you can't seem to find others, CMS is not going to look at the OPEIR measures group to see that you could have reported those. So the measures groups are just outside of the MAV process. And you can take a look at all the CMS documents associated with the measures applicability validation at this link on the ACR website. So the MAV process for the claims MAV, there are 2 steps. The first step is a clinical relation or domain test. This is done by looking at clusters of measures and which measures you may have reported. Most of the measures, a good portion of the measures in the PQRS list are put into clusters for purposes of the MAV. So you look at the measures that you report, look at the cluster or clusters in which those measures are contained, and determine if you can report other measures in those clusters based on your services. If no other measures in that cluster can be reported, then you pass the MAV and you are incentive eligible. If there are other measures that you could have reported, then the second step is to look at the minimum threshold. So if there were less than 15 eligible instances or 15 cases for which a measure that you didn't report would apply to, then you're not considered responsible for reporting that measure. So I'll walk through an example in just a minute. The registry MAV does not go through the minimum threshold, so it's basically were there measures in the cluster that you reported measures in, could you have reported others? And just to point out that the clusters in the MAV registry are different from the clusters in the claims MAV. And the main reason for that is there are a number of measures, PQRS measures, that are registry-only measures. So this is an example of a MAV cluster. It's the diagnostic imaging cluster, which contains the 5 measures that are most applicable to most radiology practices. So for example, if you reported measure 145, the fluoro measure, and measure 225, reminder system for mammograms, then CMS, at the end of the year, CMS would analyze your claims to see if you could have reported measure 146, 147, or what else did I say? Or 195. And since the CPT codes and the V codes for measure 225 are the same as 146, the inappropriate use of probably benign code, then more than likely you're going to be able to report 146. So if all you reported was 225, you probably could have reported 146, and you would not pass the MAV in that situation. So another example, if you reported 145 and 195, and as an individual, you don't provide mammography services or nuclear medicine, then more than likely 145 and 195 are the only measures that you could have reported in this cluster, and you would be considered successfully reporting and incentive eligible. There are several other relevant clusters that you might want to look at when you're looking at measures to select. In the claims MAV, there is a cluster number 15, surgical care, and those are the perioperative care measures 20 through 23. In the registry MAV, there are 4 clusters here that you might want to take a look at. In particular, the number 29, which is also the perioperative care measure set, and the mammography cluster in the registry that only contains measures 146 and 225. And just again, note that not all PQRS measures are included in math clusters. All right, let's talk a little bit about feedback reports. Starting last year, I believe, CMS made available an interim feedback dashboard, which is really giving you an idea, and that's only for claims reporting, and that is to give you an idea on a quarterly basis what CMS is looking at in terms of what you have reported. It's a reporting summary at the tax ID number and MPI level. It gives you a count of measures that you have reported and a count of accurate submissions. So you can kind of bounce that off of what you're using to track internally to see if everything's going through. It doesn't give you performance scores on a quarterly basis. That will only come as part of the annual feedback report, which is distributed in the fall following the program year. So for 2013 PQRS reporting, you would be receiving a feedback report sometime around the August-September time frame, at the same time when the incentive checks are distributed. That feedback report does include performance rates and shows you your incentive eligibility. There is also an informal review process. If you disagree with the determination that CMS has made in terms of incentive or penalty, you can request a review, and that is after the feedback reports have been distributed, that you can ask CMS to reanalyze your claims, and they will provide to you a detailed analysis of what they use to determine your incentive or penalty results. That is the quality report communication support page is where you would request that. It's a review that's available no matter what reporting mechanism you used, and their review decisions are final. The time period for requesting a deadline is typically from the point where feedback reports are distributed to the end of February the following year. Okay, so now let's talk about how PQRS and the value modifier are linked. What is the value modifier? It was actually required by the Affordable Care Act and allows for differential payment or tiering of payment for physicians groups that provide services to Medicare Part B fee-for-service beneficiaries. It is an aggregated payment differential to groups of physicians at the tax ID number. It's based on assessment of both quality and cost of care on a comparative basis and builds on the PQRS program, where performance scores are used to determine an upward, neutral, or negative adjustment on Medicare Part B reimbursement. 2015 is the first year that the value modifier will affect groups, and this is based on participation in PQRS last year in 2013 for groups of 100 or more eligible professionals. Those that did not participate in PQRS will receive a negative 1.5% penalty, and that is on top of the PQRS penalty. In 2016, based on 2014 reporting, groups of 10 or more will be affected by the value modifier. The penalty for not participating in the value modifier penalty for not participating in PQRS is a negative 2%, which is in addition to the negative 2% PQRS penalty for non-participation. In 2014, you're not required to register as a GPRO for purposes of the value modifier. And I've highlighted this because that was a requirement in 2013 for large groups of 100 or more. They did need to register as a GPRO in order to avoid the value modifier penalty. But that's not the case in 2014. Instead, you have the option to register as a GPRO, or for purposes of the value modifier, if 50% of the individuals in a non-GPRO group report PQRS. So as radiology group as a whole, if you have 25 individuals in the group and 13 of those report PQRS measures, then the group as a whole is considered successful, and aggregate PQRS scores are used for the value modifier. So again, the quality portion of the value modifier is based on PQRS measure performance. There are cost measures that are in part of the equation for the value modifier, but currently none of these apply to radiologists because there has not been a way to attribute those cost measures. So looking overall at how the value modifier will be applied, in 2013, PQRS performance year for value modifier 2015, groups of 100 or more could have received a downward adjustment for not participating, no adjustment, or potentially an upward adjustment if they chose to be assessed in terms of quality and cost. So that in last year, GPROs had the option to be looked at under quality tiering to receive a potential upward adjustment. If they didn't choose to do that, they would either receive no adjustment or a downward adjustment only if they didn't participate successfully in PQRS. So that's similar to how the value modifier will affect groups of 10 or more in 2016 based on 2014 PQRS participation. So for groups of 10 or more, there is potentially no adjustment, so a 0 adjustment if you're successful in PQRS and don't receive a higher score in terms of quality. So an upward adjustment is potential for groups of 10 or more if they do end up with in a higher bucket, so a higher quality score. And I'll go into a little more detail on this in a minute. But for groups of 100 or more in 2016, based on 2014, there is no choice to do the quality tiering. So for those groups, those large groups, there's a downward adjustment based on non-participation in PQRS or based on quality and cost performance. No adjustment if they did participate in PQRS, but their performance scores put them in the mid-range, and an upward adjustment if their scores did put them in a higher range. In 2017, based on 2015 reporting, the value modifier will apply to all groups and all individual physicians. So looking at that more in a more visual way, just basically PQRS reporters that are successful will avoid the 2% value modifier penalty and the 2% PQRS penalty. They will be looked at under quality tiering. Groups of 10 or more can only get a positive or no or 0 adjustment based on quality tiering. Groups of 100 or more will have an upward 0 or negative adjustment. So in looking at how the quality performance is determined, the PQRS individual measure scores are standardized against a national mean from previous year's participation. The Qualified Clinical Data Registry scores are looked at comparatively across the registry that you are using. There is a score in each domain, so each measure has an associated National Quality Strategy domain, so you'll receive a domain score. Each domain is equally weighted, so if you don't have, if you have 3 domains based on the measures you reported, those are equally weighted across those domains. And then those are averaged into a quality composite score where it's determined comparatively against everyone that reported those measures that you have a high, average, or low quality score, looking at -1 or +1 standard deviation from the mean. The cost measure performance uses the same methodology. Currently, there's 5 total per capita cost measures. These aren't attributable to radiology groups, so CMS has said that if you have no measures, you have no score, and that equals average cost. So looking at it visually, the 6 domains, you would receive a quality score for each of those that you had measures reported in. Those go into a quality of care composite score. For radiology groups that are single specialty, the cost composite score would be considered average. And those go into the total value modifier amount. So this is looking at how the quality and cost buckets will determine whether or not you have a upward, neutral, or negative adjustment. The potential for radiology groups to have an upward adjustment is based on those that would be determined to have high quality and average cost. The upward adjustment is determined by, it's a budget neutral program, so the upward adjustment can only be determined at the end of the year, looking at the physician groups that did not receive, that will receive a penalty, and that withholding will be used for the upward adjustment for groups that were successful. And I'm just going to quickly talk about the quality and resource use report, so we'll have plenty of time for questions. But this is under the physician feedback program. The quality and resource use reports are annual reports provided to physician groups that will give you comparative information on quality and cost. There will be some drill down information at the beneficiary level, so you can look at potentially why your scores may be lower. But it's basically, the reports are important because they will provide information to you on how your group will do under the value modifier program. So it provides you comparative information on your PQRS performance scores. While the most recent reports, which were distributed in 2013, were available for groups of 25 or more, most radiology groups would only receive a one-page report, which just basically said you participated in PQRS and these are the measures you reported. The version that is coming out this summer will include PQRS measures from 2013 and will give you a comparison across the national, to the national mean, what your performance scores would look like for purposes of the value modifier. This link at the bottom of the page gives you information on the CMS website for the QRUR report and the value modifier. And just real quickly to point out that the public reporting of quality and cost measures is basically the third leg of the value-based purchasing initiative from CMS. So the information reported back to eligible professionals, the quality scores and the cost scores as part of the value modifier program, gives you, the intention is to have incentive for improving care, and that CMS is paying for value rather than quantity. But there's also the perspective of giving that information on quality and cost performance to consumers and patients, to beneficiaries of services, so that they can make informed choices of providers. And this just gives you an idea of where CMS is in terms of public reporting of PQRS data. So that's it. Here's contact information for myself and for Colleen Talent, who works with me. And now we'll open the floor for questions.
We have one question that came in on the questions panel. The person asked to clarify, if you participate in the ACR PQRS system, it is not mandatory to participate in the QCPR, correct? And the question is based on individual physician rather than practice group.
Okay, so I think the question is that you're wondering if you're participating in PQRS, in the registries as a whole, whether you have the choice to participate in it for purposes of PQRS. And yes, that's true.
You know what, I can go ahead and unmute everyone so we can ask follow-up questions if they want to.
So if you have a question, can you raise your hand on the icon?
Muted.
Well,
and everybody should be unmuted at this point. Well, not yet.
we're unmuting everyone, so please put your phone on mute if you don't have a question.
Everybody's unmuted now.
So you can ask questions if you have them. I'm not sure that the QCDR question sufficiently, so if you ask that question, would you mind asking me again? Gloria?
Yeah, she's self-muted.
Yes, hi. All right, so my question is, as an individual physician, I participate in the ACR PQRS system, and I'm up to date in my MOC. Now, is that sufficient as an individual physician currently, in the future, or is that going to change and you have to sign up with the QCDR system?
Yes, you would have to proactively say you want to do that. We would need to know if the ACR is qualified as a QCDR. There will be functionality that you will basically sign up for that and request specific measures to be reported on your behalf.
Sign up for the QCDR, you mean?
Correct.
Okay. And is that something you do personally, or do you do through your radiology administrative person, or how does that work?
No, this is my take, Hatfield. I manage the data registries, so let me try to answer that. So the portal will be designed for every individual physician to sign up, because we want to make sure that the physician has a chance to review the data before it is submitted on their behalf.
Right.
But said, you may choose to have somebody at your facility register you and monitor the data for you, but the login will be at the physician level.
Okay. And so at this point, being signed up with the ACR PQRS is not enough anymore.
So when you say ACR PQRS, are you talking about the PQRS wizard?
So my understanding right now, or at least the PQRS I have been keeping up with as an individual physician right now, is the one that is required for the MOC, for the ABR MOC.
Oh, you're talking about the additional maintenance of certification incentive for PQRS?
Right. So is that PQRS enough to satisfy the QCDR requirements, or is that two separate things?
That's separate. That's still the additional incentive. So you are, if you're participating in the PQI projects through the registry, that's going to meet the maintenance of certification activities, but that doesn't roll over to make you successfully participating in PQRS.
Okay, got it. Since they have the same name, it's confusing.
Yes, it is.
There is another question. If the ACR is approved as a registry, what steps will be needed to submit the data to you? How will it work? So, we'll have much more detail about this once we get certified. Essentially, if your practice is already in one of the ACR registries, you're already in the DoseIndex registry or mammography database, your data will simply be identified. Every physician will be invited to this portal to sign up and register and say, I would like to have my data submitted to CMS or PQRS. At the time, we will ask you, is your facility submitting data to one of our registries? And if you say yes, we will use your NPI to pull the data from our registry to just display it to you. You don't have to do anything new to resubmit the data that are already coming through. But we also offer some PQRS measures for which every registry, every measure will have a web-based form where you can enter data, or you can upload data for based on specs, and all of those instructions will be posted online. So if you have been receiving the QNS newsletters, that's where we send out updates, and also on the ACR webpage, under the National Radiology Data Registry, there is a tab for the Qualified Clinical Data Registry. And as we accumulate more information, it will be posted there, and you should expect much more information when we get certified. Laura has her hand raised, but you're muted at your end, so we cannot hear you.
There. Laura, did you have a question?
Erica has a follow-up, but if you're not signed up for ACR currently, will it be too late in May to submit our data? No. And if we've already sent space data to Medicare, we will not be able to submit mid-year. I think you can.
Yes. That would be, you can change mid-year. If you're submitting through claims now, that's a good idea to do that. And if that does come about that the ACR is a qualified registry, you can go ahead and start using that. Whichever mechanism you're most successful in, then CMS will use that to determine satisfactory participation.
When will the ACR registry become active? The registry is currently active. The physician portal will become active after we hear about whether we are certified or not. So approximately June, July is when you'll be able to register as an individual physician to opt for this option. What are the current ACR traditional registries?
Traditional registries are those such as the PQRS Wizard. The ACR has had a partnership with CE City as the vendor of PQRS Wizard, and the ACR has had a partnership with them for several years to provide a discount to members for using PQRS Wizard. So we're maintaining that relationship. You can still use the Wizard for reporting traditional PQRS measures. Are there other questions? Well, I know it's a lot of information to think about. So you have our contact information, and this webinar is recording, and we'll post it on our website sometime next week, more than likely. Since you've registered for the webinar, you will get an email notifying you of the webinar recording availability. I appreciate everyone's time today, and please let us know if you have other questions. Thank you.